I believe our panel has been sworn in, so we can get started. To frame the discussion for this panel, I'm going to turn it back over to David.
Hi, good afternoon, everyone, and welcome back to the afternoon session of the cost trends hearings. Before we begin, did want to recognize one of our elected officials who was here earlier today, and I think we'll be back for some of the panels. Representative Christine Barber, thank you for being here. For this afternoon, we're going to shift focus to...
I just want to correct something or clarify something that was said earlier. And it really has to do about the slide that showed the trend for small employer premiums versus individuals. And I think David Auerbach didn't intend to say that there was comparability of the plans. I just want to correct that the individual connector benchmark plan that was shown on that chart, the famous employer chart, is for a less rich plan. It's actually a silver plan than what is typical in the employer market, which partially explains the difference in prices. I think it's just important. It's not, that was not a complete apples to apples comparison. And I think we need to get that on the record.
Excellent. Thank you for that clarification.
Back to pharma.
So for this afternoon, we're going to shift focus to another one of the cost drivers that was identified in the CHIA's report, which is the growth in pharmaceutical spending. Pharmaceutical spending net of rebates grew by 3.6% during the most recent time period. Not the fastest growing category, but certainly above the benchmark. So to frame up this panel's conversation, I just want to share two very quick slides. One is around just some numbers in terms of projections and survey results. So obviously projecting future cost growth is a challenge in this industry, as many industries, but we're relying here on the CMS projections for the next 4 years, 5 years, which project 6% annual growth in this sector, net of rebates. And what we further know is that there is a growing consensus among the public that further action is necessary to address rising pharmaceutical costs. So 7 in 10 individuals nationally think that lowering prescription drug costs should be a priority for Congress, and 76% of Massachusetts residents think that the cost of prescription drugs is unreasonable. This leads to 1 in 4 Massachusetts residents who opted not to fill a prescription due to the cost, with 43% of them reporting that their condition worsened as a result. We need to have incredible innovation in this sector that provides life-saving and life-altering drugs, but it is also important to make sure that patients actually have access to those drugs. We asked our stakeholders through our pre-file testimony, which consist of health plans and providers, what are some of the biggest pressures that they feel are driving healthcare spending growth, and they identified prescription drug growth as one of the top categories. We further asked them what are the strategies that they're deploying to try to reduce drug spending. And on the left-hand side of the slide, you can see some of the major categories of strategies that providers and health plans reported to the HPC that they are pursuing. Value-based formulary design, clinical education, and consumer education around lower cost alternatives. We also surveyed our payers and providers around recommended policy actions that they would recommend that we pursue in order to address rising prescription drug costs. And on the right-hand side of the slide is a summary of those results. Increased transparency for manufacturers and pharmacy benefit managers, more robust price negotiations and controls, enhanced government oversight, flexibility in financing for value-based contracting, and maximizing competition through the availability of biosimilars and generic specialty drugs. So with that, I'm pleased to have a very distinguished panel to talk about some of these trends and issues, and I'm going to turn it over to Dr. Kreider to help lead this panel.
Thank you, David. Welcome, panel. I think opening comments are in order, and we'll go right to left. We'll start with David Twitchell.
Sure, if I was on the right or the left.
Yeah.
First of all, thank you. Thanks for having me, and I'm honored to be part of this distinguished panel and with the group that I have up here. My name is David Twitchell. I am the Chief Pharmacy Officer for Boston Medical Center Health System, which involves our inpatient pharmacy. We have outpatient pharmacy. We have retail, specialty, mail order, as well as our health plan. So I have responsibility across all of those. I hope that offers a unique perspective, a holistic view of the healthcare system. We both have to act as a payer and as a retail pharmacy and as a provider, which I think gives us a lot of insight into some of the issues that we have in front of us today. A little bit about Boston Medical Center. We are a not-for-profit safety net system in the South End. We are by far the highest public payer hospital. We have 77% of our patients are public payers, 50% are Medicaid. Our health plan is a Medicaid MCO and qualified health plan. We operate in Massachusetts and New Hampshire. We cover about 400,000 lives across the two states. We do participate in the 340B pharmacy program. It's very important to our overall hospital health and the programs that we run. It's also a way that we've helped control our own drug costs and has been very important. And some programs I'd like to touch on involve pharmaceuticals both in the way that we've used them to lower the total cost of care, to improve the care that we provide to our patients. So there are times when even expensive drugs are quite valuable to what we do, even though we're frustrated with some of the drug prices ourselves. And I'll also talk about some of the programs that we've done to lower the drug costs. So how do we eliminate waste where it exists? How do we control unnecessary utilization? We've got a couple of examples there. And I'm honored to join the panel and discuss the policies that the state has already enacted, and we'd like to talk about how we think some of those are great ideas and how we'd like to see more of those. Thank you.
Thank you, David. Erin Mistry.
Good afternoon, everyone. I'm Erin Mistry. Again, thank you for having me as part of the panel, and look forward to the discussion. I represent Syneos Health. For those of you that don't know who Syneos Health is, we are a 25,000-person organization across the globe. We provide all disciplines that are involved in bringing new therapies to the market, both on the clinical side through clinical trials and on the commercial side through marketing, pricing, landscape assessment, launch strategy, any kind of commercial strategy that's involved with that. With that said, we work with emerging, mid, and large pharmaceutical companies and biotech companies. And where my role is within the organization is I lead our value access and HEOR practice, which is the health economics practice, and work with clients on a global level. And what that involves is anything from looking at what they're putting in their clinical trials from an evidence perspective, their pricing of the pharmaceuticals, landscape assessments, reimbursement criteria, all of those types of things that would potentially make them most successful in the market and get the product to the right patients. I think one of the things that we have seen in the value and access space over the last 10 years, most recently in the last 5 years, is that the bar for approval is obviously been set much lower than the bar for access. And so drugs are coming to market quicker, which is a great thing for the patients. Oftentimes, though, that's with smaller clinical trials. The data that's involved in those clinical trials is not robust. And so a lot of companies and manufacturers are relying on real-world evidence. A lot of that is driven through payers that we're seeing as well. And we have seen a sophistication from that perspective, right? I think that manufacturers have come a long way to try to really identify not only surrogate endpoints, but what is functionally meaningful to patients, right? Things that are going to impact quality of life, whether that's a 6-minute walk test or whether you can take a shower and get up and do daily activities. Those are the things that are really impactful to both patients and their caregivers. And we've seen investors look at potential products preclinical and say, what is the commercial viability of this product, right? And that has been a significant change that we have seen recently. Now we are working with potential investors to say, is this product really reimbursable when it comes to the market? What's the market access environment look like in 5 years? Some of those things we don't know, but we try to kind of help them figure out where to put their money and how to invest it appropriately. And I'm sure we'll get into lots of parts of that discussion, but I'd like to move on.
Thank you, Erin. Michael Carson.
Thank you very much. Good afternoon, everybody. It's nice to be able to be at this table and see some familiar faces now that have been here for a little bit. Again, Mike Carson, CEO of Hover Program, think everybody knows, non-for-profit regional health plan serving about 1.2 million members across New England, and then significant amount of population health customers across the country. Thank you to the commissioners of the HPC, David and staff, clearly Secretary Sudders, thank you very much for letting me join you today. Just a few opening remarks that I'd like to share to give some perspective from where we sit, and in particular on some numbers that we see, frankly. So for us, and I very much look forward to the conversation, clearly as a health plan, we take our role as a fiduciary holder, a fiduciary responsible party in looking out for our members and our customers' healthcare dollar very seriously. So as we look at that scenario, the balance of cost and quality, meaning value, when it comes to drug spend, is highly important. We've been able to make some progress in having value outcomes-based contracts with pharmaceutical organizations, but it's very limited. There are lots of things that we're trying, but it's not had a widespread impact on overall pharmacy costs, and we can talk through what some of the reasons are, what some of the barriers are. I'm sure the rest of the panel will also be able to talk to that, but we're very much focused on value as an organization, because we understand that innovating new drugs and new treatments is important and it's good for our members' health, but there has to be a way of proving the value of those drugs and then obviously financing those drugs. The other component that we're very much focused on is engaging members and collaborating with providers, with vendors, PBM vendors, and all of the components of the healthcare system to achieve the best member health outcomes. And oftentimes that means that we have to find new innovative ways to educate, to engage members as well as provider organizations in that effort. So a collaborative job needs to be done in order to address drug pricing. But a few stats I think that are important, and David, you did a great job with your 2 slides summarizing some of these that I wanted to highlight, perhaps help set the stage as well. 1 in 4 healthcare dollars are spent on pharmaceutical expenses, so 25%, and it's increasing. Overall, you're seeing a 20% increase in drug spend versus an 11% increase in medical spend. When you look underneath the covers there, you see specialty drugs with a 9.5% annual increase, 18 over 17, injectable drugs with a 29% cost increase, while medical trend is 2.4%. So significant outlier when it comes to overall trend. It was great to see, and great to see the impact of the Health Policy Commission of Massachusetts and us sticking to our 3.1% target, but clearly there are components and there are forces that are driving that number up as well, which impacts our members and customers. And then, finally, another number which potentially has some risk at being controversial, but the reality is that not all of the healthcare system is treated equally. An average pharmaceutical profit margin is about 30%. That's after R&D. For a non-for-profit regional health plan, generally you're talking about a range of 0.5 to 1.5. And I only share that to give perspective of where the money is flowing here. This does not mean that there aren't more ways to be efficient as a health plan, as we saw from the previous panel. I'm simply pointing out that when we look at the entirety of the healthcare system and we want to make better use of our healthcare dollar, we need to understand where that money is going and how that's flowing through. So that the entirety of the drug cost issue, while we try to, again, be fiduciary responsible and do as much as we can with it, I think it's a bigger challenge than a health plan can handle on its own, which is why I'm happy to see the panel representation and clearly happy to see it being a topic here for discussion as well. So with that, I'll pause, but
Thank you,
looking
Michael.
forward to discussion on that.
Thank you, Michael. Dr. Brennan?
Yeah, so I'm Troy Brennan. I oversee the healthcare and medical affairs at CVS Health. That includes our CVS retail pharmacies, our retail clinics, which we call Minute Clinic, our pharmacy benefit management company, which we call Caremark, and our insurance company, which is Aetna. And I'm looking forward to the discussion.
Thank you. So I thought I could lead off with a prop, but I can't, because while often there are pharma articles on the front page with targeting you guys, it's all politics today.
Yeah.
So, whoop. But we could talk about the vaping ban or about in the Globe, Vertex's new drug, but thanks for that, Mark.
You just had the wrong paper. You needed the local one.
Read local.
So we were reminded this morning that we are regulators. The governor was here at 10 o'clock, talked about his new bill. And if it passes, there's going to be things that we have to get involved with. We've learned if it passes, we've learned that we may have some new responsibilities. There's some new regs for PBMs, which I think are yet to be defined, as well as some new pricing scrutiny. And I think $50,000 drugs was the threshold. So I'm going to borrow from my colleague, Dr. Berwick's line of questioning with administrative complexities. Why don't we go down the line? If you had, and this time we'll go left to right. We'll start with Troy, my left to my right. If there was one single regulatory action that you think we should be contemplating, or if there's a perhaps removal of a single regulatory barrier, what would it be?
Related to drug pricing.
That's a good question. I guess I would recommend a certain aspect of transparency. I know that there's transparency that's discussed in the governor's bill, and that's obviously important. The part I'm thinking about is sort of the transparency with regard to the information on the pricing associated with the drug. And we aim that to provide that transparency, of course, to all of our clients. They have complete transparency to the contracts they have with our Caremark PBM. But we also attempt to get transparency to individual patients and to providers and to retail pharmacies. And we can provide that information, what we call real-time benefit information, in basically sort of microseconds through a computer to anybody who's interested in it. And we do make that available to doctors through their electronic medical records. We make that available to our patients on our apps, and we make it available to retail pharmacies as they're adjudicating the claim. The problem that we have is that, especially with regard to the physicians, is that there is limited sort of space on their electronic medical records. So we work directly with the electronic medical record providers to try to get that information into the hospitals and integrated delivery systems and doctors' offices. But that's a struggle. So we've been successful now. We probably have about 200,000 physicians who are actually looking at this information. But if I was making one sort of simple recommendation, I would require that the EMRs make available the real-time benefit information from the PBMs. What that does then is that enables the doctor to look and see what the costs are associated with the medication. And also in our process, through their EMR, we'll process this in any EMR that exists in the Commonwealth today, we'll also provide them with 3 alternatives and give the costs associated with those.
So sort of a good RX app for the EMR.
Well, we wouldn't call it that, but yeah, yes. And
I mean,
this is
ideally,
as
right?
I say, this is available today. But what it does is, if it gets into the prescriber relationship with the patient, then it enables us to avoid a whole set of administrative costs associated with and the situation in which the patient goes to the retail pharmacy and finds out this drug costs this amount out of pocket, because this real-time benefit information will say not only what the drug costs, but also what the out-of-pocket spend is going to be for that individual. So I would say that's a very simple thing to sort of insist on, but it would dramatically sort of reduce costs because people would be getting on the right medications from the outset.
Thanks, Troy. Michael Carson.
So many at so little time. I would say that, a few come to mind really quick. Clearly, the use of an organization like ICER to establish the fair value list price in a more structured and mandated way would be appropriate. Ensuring that there's competition so that we don't have.
Well, you only get one.
I know. Well,
But that's
I'm
good.
leading up to the one.
I
There
mean,
needs to be competition on drugs.
let's start with one.
The lowest price policy, I think it inhibits some of the value-based contracting that we're trying to make. But the really big one, this is my one, Chris, is when you look at health plans, we're subject to 85%, 88% medical cost ratio targets, where we have to ensure that money is spent on care delivery, right? Nothing like that exists in the pharmacy world. So I don't know what the answer is, but there needs to be, again, more fair regulation across the healthcare system in order to address that. You can't just squeeze on one side of the bubble.
So parity
So some
of
parity
of pharmaceutical
in terms of
spend.
correct, spend.
That's not the injectables under the medical spend. You're talking about the,
That's
pure-
correct. That there need to be, the 85% and 88% thresholds mean that we're required to manage to a certain margin, we're required to manage to a certain
Okay.
administrative cost ratio. That does not exist.
right. Aaron?
Other than list versus net, I would say that one of the big things is to look at the medical loss ratio and look at a patient's health medical records holistically, right? So oftentimes we have the pharmacy benefits in your pharmacy and your RX prescriptions, and then you have your medical benefits, medical data, which is on two different systems, right? And oftentimes the medical data lags the pharmacy data, which is a bit more real time. So to truly do things like value-based contracts with integrated delivery networks, outside of surrogate endpoints, really looking at the patient's holistic medical view and how they're utilizing the healthcare system. And what that does is it shows the true healthcare costs that they have accrued over a period of time. And so when a therapy comes to market, you can identify ways it has truly saved on those costs. And right now, it's very difficult to do because typically the medical claims and the pharmacy claims sit on two different systems.
So is that a little bit like what Michael was suggesting with ICER? Take a nice NICE-like approach
I mean,
for value-based contracting?
NICE is quite a bit different than what I'm talking
Okay.
about. NICE is, if you look at the EU, the access to latest and greatest medicines is often, it's not allowed, and it takes years to allow for that, to provide that access, and often years for reimbursement. So it's a quite a bit different system over there than that, but I think there's an opportunity to really look at the holistic view of the patient, which we don't do right now. We look at surrogate endpoints.
Okay, thanks. David?
Yeah, I'll echo some of what Troy and Michael said about transparency, and actually would applaud the governor's bill and the secretary for bringing this up. This commission has already issued a statement, which I read, on transparency and PBMs. If I had one thing that I'd like to see, would be full transparency in that space. I think it opens our eyes to a number of different things and hits on a number of the reasons why pharmaceutical spending is going up. You mentioned gross to net, so that gross to net bubble and the fact that sometimes the prices are being driven by the PBM, but sometimes they're being driven by the pharmaceutical companies. And to know that, you actually need the full transparency to see where all of the sources of value are. You mentioned the margin in the pharmaceutical company. It's easier to see once you can see all of the pieces of the funds flow, so to speak, within the system. So if you can't see that, it's actually quite hard to be strategic and pick out the 1 to 2 things you can do to actually lower price. You can end up pulling levers that have nothing to do. And at the health plan, we are struggling mightily to find ways to find dollars, but it is more difficult when you don't have a full picture. I also think we can link the things between the medical benefit. I think it's a great point. We have a great deal of ability to do that, but it's much easier when you own the data, when the data is completely transparent. So I would focus a lot on that.
So, Mary Lou, one more point. So on transparency, Troy, you mentioned your contracts for employers show full transparency. I think this is a different transparency. This is transparency right down to the consumer, and and getting rebates to flow back to consumers, or what's the?
I think I would emphasize that transparency to the payer. I would disagree that PBMs are fully transparent to their plan sponsors. There are options to do that, but I think it is a system that is not fully understood, and I think I think the experts in this field would tell us that there's more to open up and more transparency to be had. I don't necessarily think forcing rebates back to the consumer. I think understanding where those rebates flow is important, and then you can make decisions on what the best way to do that would be.
Want to respond to that? No.
I got a client on the panel here, so, I would suggest that, you know, most of our clients feel like they have a pretty good understanding of what their contracts are with us, and they're also advised by expert consultants, by and large, when we do a RFP. So I guess I would feel like it's like the rest of commerce, where, you know, two people who are contracting, it's usually pretty well understood that both parties are going to understand what the contract looks like. There is a longer discussion that would be dominated by the economists about whether or not, if we went transparent with what rebates were, whether or not they would actually sort of improve our ability to get higher rebates and as a result reduce costs overall, or whether or not there'd be an aggregation around certain numbers as the pharmaceutical manufacturers saw what was being offered by their competitors. And you know, CBO's got a long discussion about that. They actually end up thinking it's probably not a good idea to be completely transparent. That is, make rebates that we get from the pharmaceutical manufacturers available to everyone in the public. But that's certainly a debatable issue, and economists debate that. But by and large, we do feel like our clients, we've tried to sell BMC in the past, but we do feel like our clients understand the contracts that they're signing up for. And most of these contracts today are very much pass-through contracts. So, you know, it's very clear sort of what they're going to get back in terms of rebates, what sort of pricing is going to be associated with the individual retail pharmacies, what utilization management criteria we're going to be using, what formulary they're going to be on. So it's a sophisticated audience.
Okay, thanks. So Secretary Sutters, let's open it up.
So I find the whole pricing of drugs to be completely opaque. Just going to say it. I appreciate the fact that you would say your contracts are clear. I would ask, would you be willing to say what your price spreading is among your contracts to the Health Policy Commission? Or what is it you need to make in terms of, for a pass-through in terms of administrative costs? I would ask, what is the value of a PBM? I'd like to think that I'm reasonably sophisticated, and having tried to understand what the value chain is on drug pricing in the Commonwealth seems completely opaque to me. I get it. I get great rebates, but I get great rebates because, as you know, there's actually a penalty when you set Medicaid rebates. The more a drug is inflated, the greater rebate I get in the Medicaid program. You can use Lyrica. You could use lots of examples out there. I'd love it if the rates were just fairly priced, so I wouldn't even have to get into a debate as to whether we need rebates at all. So I guess my first question is, I think 30-some states have now regulated PBMs. Massachusetts, the governor's bill also proposes sort of certification of PBMs. I'd love to know what your opinions are, what the value proposition is on a PBM in the healthcare market in Massachusetts. That was my most non-provocative question.
David?
And I don't want to interrupt this contractual relationship, so maybe the two of you need to, I don't know.
So first of all, I certainly feel like a greater transparency is needed. I think for the value that the PBM brings to us as a health plan, it is very difficult for any individual, especially a small health plan like ours, to face off with pharma and try to negotiate better prices or better rebates for a small group of patients. 400,000 feels big to us, but they're used to dealing with much larger groups. So whether it be Caremark or Envision or any PBM, they can aggregate lives, and then they actually have the ability, and I think Troy and his group do a great job of facing off with pharma and saying, we expect a better price. We know these things are equivalent in clinical outcomes, and we're going to drive our membership to use that, and as a result, yield a better net price. And if those are passed through, then the plan and ultimately the member in the healthcare system saves dollars. I do agree, though, and I think the fact that so many states have passed a legislation, including us, right, you know, is a reflection of the fact that it's not as transparent as I think we would hope. And I applaud the action. I hope that we take the best of the regulations out of other states to make sure that it's very clear to all the sponsors, and maybe it's not the public, but certain those that are paying the bills are owed the information in a clear way. And if that's true, you know, the next time we're up for RFP, we'll certainly look at Caremark and make sure that we consider your transparent contracts. But I do think they bring value. I think they're often demonized in a way they shouldn't be. I think we ought to know what we're paying for.
So,
Yeah, we might as well get the direct response, right?
Go ahead, direct response.
Well, a direct response would be, I was in healthcare for a long time before I ever went to work at CVS, and I couldn't
That's still
spell.
healthcare, isn't it?
What's that?
Isn't it still healthcare, CVS?
Yes, it is.
Just
I said
checking- just
before I
checking,
went to
Troy.
CVS and the rest of healthcare. But the point I was going to make is that I couldn't spell PBM when I got there. So, it is complicated. But when you break it down, it's not all that complicated. And if you wanted to sort of be as clear as possible, what you would do is you get a rebate contract from us. And the rebates are based on, we've got a drug category. It's got 3 drugs in it by 3 different manufacturers. We negotiate with them in order to be able to get sort of the volume that we'll be able to return, because we'll make that the only drug on the formulary. They're willing to lower their price. That's the rebate. We use rebates rather than discounts because of some sophisticated issues associated with antitrust law that were decided back in the early 1990s. So, but we get those rebates, and then I would suggest just get a 100% pass-through contract. And then you've got the ability to, you've got your contract, and you've got the ability to audit that contract, and all those rebates are going to come back directly to you. With regard to the other major place, there's 3 other places where the PBM would help out. The second one would be basically with regard to the relationship with the retail pharmacies. And we have a big retail pharmacy, so we understand this from sort of both sides of the question. There's basically 2 contracts. One would be considered a value-based contract. We'll take the risk, and we'll guarantee you a certain amount of money back from the relationship with the retail pharmacies. That's so-called spread pricing. Or you can just get exactly sort of what the discounts are that we negotiate with the pharmacies. And that negotiation is really no different than what Michael would be negotiating with the hospitals in the state. In other words, you're trying to sort of drive the lowest cost possible in terms of sort of what the retail pharmacy, and we see that from the retail pharmacy side. Then the third place where we would provide value would be with regard to utilization management. And the utilization management is a matter of sort of setting the formulary and then setting criteria that are based on what we're going to decide is an appropriate drug for an appropriate condition. Unlike the rest of healthcare, we actually have to have an independent group of doctors, our so-called P&T committee, that cannot have any conflicts, so they can't be working for pharma, and they work for us on an hourly basis. And this is required in Medicare and in many of the states where we are regulated. And they have to approve all the utilization management we do. But then basically what we do is we make sure that if somebody's going to treat somebody with a high-cost drug, that it is something that the state of medical custom would say, this is the appropriate therapy. Fourth area is that we improve adherence and try to drive use of generic medications. I think generic medications are a great value in healthcare. Certainly all the comparative effectiveness demonstrates that. And then we try to drive adherence, because the more adherent people are, especially to generic medications, the more overall healthcare costs drop. So I would say, when you look at it that way, it's relatively straightforward in terms of what we're doing. And you can make it even more straightforward by simply sort of choosing that I want complete transparency. I don't want you to take any risk on rebates. Just give me all the rebates you get. I don't want you to take any risk on the network. Just hand me back all the discounts you get from the retail pharmacies. And plenty of our individual clients do that. And I'd say there's good competition. If Michael or BMC, puts out an RFP, we go, so do the 4 other major PBMs, and we're driven to try to get to the lowest price possible. And as a result of that, things like retention of rebates have basically sort of evaporated in our business. With regard to the question about regulation, at Aetna we're regulated in every state. At CVS Retail, we're regulated in every state. We're regulated in quite a few of the states on the PBM basis, so we're open to regulation. We think it's not a bad thing.
Okay, thanks. Aaron, I interrupted. You were about to.
No, I was
Jump
just
in.
going to mention about, I think one of the challenges that we see is from a transparency perspective for the manufacturer, is to really understand what is driving certain things, right? We're driven, whether you're human or you're a company, you're driven by incentives, right? Incentives drive behavior. And there is an incentive to provide more rebates. But if a manufacturer, and let's say they're preclinical, they're looking at developing an asset, how can you really drive innovation, right? Really, truly driving innovation is not downward pricing pressure on the back end to drive them towards generic prices, right? That's not going to incentivize them to want to take the risk, already being 1 in 10 products that make it to market. They're not going to want to take a risk of doing 12 years of drug development only to get to market with a generic price, right? You're going to evacuate people from that industry. It's just a natural way of business, right? But how do you incentivize? How do you incentivize it? And if you're truly incentivized for innovation, then when you get to the market and you have proven with data, with outcomes, or maybe you're under a period of time where you need to prove that in real world setting, can you get the pricing, a premium pricing, without a lot of payer controls, right? So right now, you may get to the market, you maybe step through a generic, which may fail, and then 6 months later, you're on another brand, which may fail. You may have to step through 2 or 3 products, get a medical exception before you actually get to the product that might work. But during that period of time, you have been in and out of the hospital, you have used other healthcare resources. So what we need to do is really to drive innovation, is to know that when a product gets to the market, that it's going to get what it deserves, right? And that may be through more collection of data, what I was mentioning before, more of the holistic view of the way that we look at things. But from a manufacturer perspective, after you're already 1 in 10, right, to get even commercialize your product. And then when you start to commercialize your product, whatever list price you list it for, before you even sell the product, you're already at 75%. You're already giving away 75% of the drug, typically. So if you take a competitive class, you have your list price, you have whatever you rebate, typically you provide in the commercial insurance world an out-of-pocket copay, right, card or some sort of coupon, not as much in Medicare, but you're seeing ways around that. Then you have your cost of your goods. Then you have to distribute the product, so you have to contract with your distributors. Then you may have a hub support service. So at the end of the day, if you have a $100 list price, you're now down to $15 revenue that you're making, right? And then sometimes we have companies that come to us, and sometimes we'll run that gross to net and say, you know what, you're not viable as a company. You're an emerging company. Now, this may not apply as much for big pharma because they have a little bit more resources and pipeline and portfolios, but a lot of times companies aren't even viable at the end of the day. They cannot make it from that perspective, and they have spent 10 years to try to get this product to market. So I think if we're going to open up transparency, then we should open up that piece of transparency as well.
So maybe
Thank
I
you.
could
Go ahead, Mark.
round out on the PBM question. And clearly, I'm not a lobbyist for the PBM industry. However, what I would say, though, is that, as has been stated, we're dealing with a very complex healthcare system. And there are benefits to having specialized solutions that are part of the system at the right price point. So to me, there's PBM competition, as Troy pointed out, which enables for the appropriate transparency, since we're talking about transparency, of prices of services delivered. So it's, again, I go back to value. A PBM has to come to the table, offer particular services. In addition to its pharmaceutical pricing, it has to provide services that distinguish itself from its competitors, and it has to do so at a cost point, at a price point that a health plan or whoever the buyer is will accept. So I think the competition that exists in the PBM space, as well as the complex nature of the access to care and access to drugs and how complex that can be, requires some specialized solutions. Troy pointed some of them out. I think there are online experiences that are developed. If you don't have the PBM, if you're not paying a PBM to develop some of those resources, you have somebody else spending the money to develop those resources for members and accounts. Members and accounts require those resources. So I think it comes back to the cost management element of it. What I would point out, though, I'm not sure it's about rebates. I understand it's perhaps a fun thing to talk about, I don't know. But it's not about rebates. It's about the list price. Rebates apply to 8% of the drugs that we dispense. So it's 90% are generics, so it doesn't apply there. 2% don't have competition, so it doesn't apply there. So it's about 8%. It's not about the rebates. It's about the list price that we've been talking about.
Yep.
So I just want a quick follow-up, and then I'll, so I guess I'm glad it's clear between the PBM and their client, but it's certainly not clear in terms of the list price to the consumer. So it's great, it's clear for all of you, but certainly for consumers, and I'll take Medicaid out of this for the moment, that it's certainly, if you're asking consumers, they'd say they're paying a lot more for their pharmaceutical products. So maybe clear for all of you, but my guess is if you're a consumer, it's not clear to any of
Yeah,
us.
just to be clear, I wasn't talking about the list price being clear. So that's not what, I'm talking about the services.
Or the out-of-pocket cost to a consumer.
The services
So there
that
might
are-
be value for you. I'm trying to understand what the value is for the consumer in this conversation.
Right, and those, some of those
I
things. were-
appreciate the adherence, that's very important, we
Right.
know, and these are life-saving
but-
medications. But I'm understanding what the value chain is here
Right.
for the consumer.
I would just say on the sort of, on the whole issue about sort of list price and out of pocket, it is true that the rebated price is for the client. So the individual client is getting those rebates back. That's going back to the benefits manager at a corporation who's our client, for example, or back to the CFO at the insurance company who's a client of ours. I think people are clear on what the costs are. I think they're just very surprised because what happens when you've got a co-insurance situation, or especially when you're in a high deductible plan, what you're seeing is basically the list price of that drug, not the rebated costs associated with that drug, and it's very surprising to people. So we take steps to try to address that, and I just talk about two of them. One is that you can put the rebates in at the point of sale. So we can actually deduct the rebates. If the client wants that, that means less money comes back to the client centrally, but it means that the person standing at the pharmacy counter has a lot lower costs associated with it. We operate a point-of-sale rebate plan in Medicare, and we offer point-of-sale rebate to all of our clients in the commercial space. And I'd say the other important thing is that, you know, we at least have sort of we feel like we've taken the lead in terms of trying to expand what is considered the preventive drug list, which was something that was put into the original HSA legislation that made in the federal government that made high deductible plans really possible. And that says that you can have zero out of pocket or zero contribution to the deductible for drugs that are considered preventive. And we've expanded that preventive drug list to include all generics and including insulin. It's still probably not enough. And the place where we really look at it is in diabetes. We're now in the process of designing a plan that's basically zero out of pocket for all your diabetes care. We actually feel like by doing that zero out of pocket for all the diabetes care, it'll mean that you would think it might be more expensive for the individual client because the member's not paying anything at all. But what happens is that people are more adherent to their medications, and as a result of that, overall healthcare costs drop, and we can show the clients that they're actually going to make money on it. But that's really important as you begin to think about all the medications that are stacked up today in terms of the appropriate care for somebody who has either type 1 or especially type 2 diabetes. So I think we're taking steps in that regard, but it is a problem that the rebate system operates on the list price, and that's not what somebody in a high deductible plan sees when they go to a pharmacy. And so they have this horrible conversation with the retail pharmacist about sort of what they should do.
But I think to your earlier point, if you embedded the retail price into the EMR, you could go a long way to diffusing that
And we can
complexity.
usually show people a zero out-of-pocket medication that's an alternative to what's being ordered.
David Cutler.
I want to make one comment, which you may want to disagree with, but then ask a question. And the comment follows on this discussion, which is, I think particularly with physician injectable drugs, but also with outpatient drugs, I think everyone in the system benefits from high list prices with the exception of the patient, who at best, if the rebate is done at the time they get to the CVS, is unaffected. Whereas everyone else makes more money when the list price is high. And that doesn't strike me as a very good set of incentives to have. You may disagree with that.
I disagree.
Okay. Certainly in the case of the physician ones, the doc gets paid based on the list price, generally, for example, from Medicare, and so that doc is going to do better when the list price is high.
You said everyone. I disagree with everyone doing better.
The question that I have is about specialty drugs. And I know nationally, the cost sharing for specialty drugs is really high and it's getting higher. And so what's happening is we're taking people with severe chronic illnesses and we're making them pay a lot of money for their medical care. And we saw this when we did our hearings on coupons, where a lot of patients told us, you know, my insurer has me paying such a high price, even though my child needs this regularly, that I literally can't afford to buy the thing if I don't have the coupon. And so I wonder, how, and I think the economics of it are, you can keep my premium low because I don't have rheumatoid arthritis if you make the person who has rheumatoid arthritis pay a lot of money when they go to the CVS or when they go to get their injection. And that's perfectly fine for me because I don't want to subsidize the person at Harvard University who has rheumatoid arthritis. So like, that's all great. And if that person left Harvard University, we'd all be much happier and so on and so forth. Is that something we should worry about? That is, if I were to do some look at health plans in Massachusetts or cost sharing in Massachusetts, how much is someone who's taking a specialty drug paying out of pocket? And should we as a Commonwealth worry about that? Should we be doing something about that? Or do you think, no, we're okay, we're kind of fine, it's the rest of the country that's at issue?
Unfortunately, I can't quote what the out-of-pocket cost for that member would be, but I would say from a general perspective, we need to address it. And I still point back to list price in terms of being able to address cost of drugs that don't have competition and come to market at such a high value.
But in this case, I'm talking about the cost sharing. I'm talking about the out-of-pocket price, not the, so the total price is whatever it is.
Right.
$30,000, $50,000 a year, and then the question is how much is paid by the individual and how much is paid by the plan.
Absolutely. So unfortunately, I can't quote sort of what particular cost outlay would be at the retail point of service point. But overall, what we're seeing is that the coverage of drugs through the premium is actually increasing from 82 to 88%. So drugs covered, and then deductibles or out of pocket staying generally the same. I would have to get back to you on details regarding that particular drug or that
And
particular instance.
like the high end, if I were to think about it, so if you take someone with the, I don't know, top 10 chronic expensive med conditions, how much is a person looking at in a year? Out of pocket, in addition to leave aside the premium.
I can't answer you.
I can give you sort of what the experience is for us. On a 30-day script, the average out-of-pocket in 2013 was $11.96. And in 2018, it's $10.95. Now, David, that's basically sort of all comers. I'd like to make two other comments about the high cost situation. First of all, the sort of out-of-pocket max issue is an incredibly important issue, and especially in Medicare, you know, we have a situation where people can spend literally tens of thousands of dollars out of pocket. There's a very good article by some researchers from the Harvard School of Public Health in JAMA this week that's got a very nice graph that sort of shows 4 different approaches to reform in Medicare Part D and what the cost would be for the various different players associated with it. So I think, you know, there's a lot of ways you can go on that from a regulatory point of view. On the other hand, I would say there's, because coupons have been mentioned, if you're a expensive drug manufacturer and you realize that, at least on the ACA now, the out-of-pocket max is somewhere around $7,900 or something like that, if you coupon the individual, you give the person a coupon so that they can get the medication basically sort of for free, up to $7,000, then you're free and clear after that because the person's got no more sort of out-of-pocket, and then the judge just going to adjudicate with no cost to the individual. So there is obviously a strategy on the part of pharma to basically sort of get people over the out-of-pocket max, and then then at that point, you know, they're not concerned about the price, and you know, we're dealing with whatever it is that they can come through, especially with regard to drugs that don't have competition and have relatively sort of long-term patents. So that's a problem that the PBMs have been attempting to address by not allowing those coupons to adjudicate against the out-of-pocket.
Don Berwick.
Thanks all. It's a bit of a Groundhog Day. I want to go back to rebates one more time, then I promise never to mention it again. I've tried over and over again to understand them, but I don't understand it. I think I understand the politics of rebates, but the logic escapes me. Why you just don't bake whatever the discount is into the price of the drug. And Troy, when you were talking, you said there's some antitrust opposition. This is actually a technical derivative of some law. So my question is, can you explain that a little bit, enough not to blow our minds? And then also, could the state change that?
Well, I could explain it a little bit, but my legal team gets very nervous whenever I start talking about the law, Don. So, but it's basically a sort of relationship between, in the antitrust law, with regard to sort of discounts between competitors and the intersection of that with the fraud and federal fraud and abuse law. So that there were a series of cases that were being brought that because the retailers wanted to get the same discounts as the PBMs back in the mid-1990s. But they didn't really control the volume at all. The PBMs had the formulary, and so we could decide, the PBMs could decide, this is on the formulary, this is not. So the retailers wanted to get the same discounts, and there's specific criteria in the antitrust laws that say if one person gets a discount, the others get that discount. So that's when it moved to rebating, and it was a very specific exception was carved in as a safe harbor for rebates in the fraud and abuse laws to allow that to go forward. It's exactly that which the Trump administration was looking at when they were thinking maybe what we should do is get rid of rebates in Medicare Part D, a proposal which they had subsequently sort of pulled back.
So far as you know, is there any way, suppose we in the state here said, let's get rid of rebates. It's really a discount. It should go to the consumer and the story. It should be baked into the price. Could we do that, do you think, or is this preempted by federal antitrust laws? Do you have any idea?
There would be smarter people than me, but that would be able to sort of talk about the relationship between what the state might be able to do. But in these ERISA-based plans, they usually are going to be able to sort of do what they want to do, independent of the state law. But point-of-sale rebates, requirements around point-of-sale rebates, are the kinds of things that some people are thinking about.
What share of plans are used, what share of buyers use the point of sale rebate?
A very small. We've offered it for years, but it's probably less than 10% today.
They want to keep the rebates on their own and just do
If you're a
whatever they want
benefits
with it.
manager and you get rebates, then you can use that to sort of adjust the premium. And for them, by and large, what they're thinking about is sort of what the premium is for the individual. It may not be an appropriate way to go, depending on sort of if you think that's unfair for people some of your employees who are going to get sicker and they're going to be facing sort of higher costs out of pocket.
David.
This question's for Aaron. I appreciated your comment and a question. I appreciated your statement around, the list price and then all of the different pieces down the chain, taking a little piece of that, taking a little piece of that, and so that the profit or the revenue coming back to the manufacturer is different than what that list price is. But the patient is still oftentimes paying their out-of-pocket or coinsurance based on that list price. So that's a comment. Help me walk me through a scenario where there are existing brand name drugs that are already on the market and that are having super inflationary price increases. And I'll give you, there was a recent study that of the top 25 brand name drugs on Medicare Part D, 20 of them had list prices between 2016 and 2017 that grew above the inflation rate, ranging from 3 to 9 times the rate of the inflation. So the cost structure is not increasing 3 to 9 times year over year for a drug that's already to market. What is driving that pricing strategy? And extra points if you don't say rebates.
I'll say incentives. One of the challenges with manufacturers in these competitive categories, right? You're not going to rebate if you're not in a competitive category. I mean, most of the time, you may do a value-based contract or something like that, but most of the time, you're not going to rebate unless you're in that, because you want to be one of 3 or one of 4 or one of 2, and then if you want to be one of 1, then you're going to heavily rebate. I'm sorry, I'm going to say it, but you are. I mean, that's the nature of the game. But from a manufacturer's perspective, the net price isn't changing, right? So they're incentivized, unfortunately, to move up their list price to provide a bigger incentive to get on formulary, right? And if you want to buy down from a non-preferred brand to a preferred brand, then you're going to incentivize that plan even more so. So your list price will go up, but your net price may remain the same or even be reduced. And that's the driver for a lot of if you look at contracting and rebating strategies for the next 3 years up to loss of exclusivity. There's a period of time where manufacturers are on the market that they're able to gain revenue from a product before it goes generic, right? And that clock starts ticking a lot earlier than what people think. It's not when the product launches on the market, it's when they file an IND. So that clock, by the time you get on the market and you may have more competitors that come on, you have a limited time to actually to make any money and maybe offset a lot of healthcare expenditures, right? I think we're really not looking at some of the offsets that are occurring in the healthcare system. Right now, does that justify an $800,000 list price? Maybe it does, right? We look at Zolgensma that came to the market. Now they've come up with ways to make that more affordable for both payers and patients where they're amortizing it out over time. So that's an opportunity. But the reality of it is that you have one, if you're a manufacturer, you have one time to set your list price. You have one chance to do it, right? Unfortunately, that's the way the world works today. If there's an opportunity, and maybe there is, where you can, if you create like a 2x2 matrix, right? So where you have I put products in two categories. You're either incremental, right? You make an incremental change, or you make a transformational change, right? Transformational tends to be your gene cell therapies, maybe cures. Your incremental is maybe another, you may have a slightly better outcome, or it's a Me Too product or something like that. It's good, but it's not great, right? So it's incremental or transformational. And then I put companies in the category of you're either traditional or you're progressive, right? So you're progressive in that you're willing to take risks, you're willing to work with Harvard Pilgrim, CVS Health, folks that are a little more progressive on the industry side to try to find ways to make payments affordable for patients, right? So one of those ways is to amortize things out. Another way could be to rely on data. So you set your list price, and if it's really working in the real world setting, then maybe there's an opportunity to get a premium for that. And if it's not working, maybe there's an opportunity to lower your price or remove yourself off the market.
So for the audience, the reference was to Zolgensma, which is the drug for spinal muscular atrophy. It came on the market. It's the most expensive drug, $2.1 million, I think it's priced at. You know, and for that one kid, right, or for the
right. But in the
13
same
kids in Massachusetts, right? I don't know what the number is, but it's obviously it's a lifesaver. Let's go to something else, to a related subject, but have the payers ready to talk a little bit about value-based contracts and how that's going to play out. But before we go there, let's talk about drug development, the cost of drug development. That Zolgensma really is a vivid descriptor of that problem. How do you price? So biotech, biogenetics, biopharma in general, it's a crucible of the Massachusetts economy, right? It is. I don't think we have any manufacturers in the room, but it's a big part of our economy. Is there anything we as a state can do that's different to help reduce the cost of drug development? Could there be a registry for data, for failed clinical trial data that the state could administer, maybe a public-private entity, to make available failed data and reduce the cost? Forget the pricing for a moment. Let's talk about how you can actually do something good to reduce costs. Is that plausible? Is that a good idea? Bad idea? Anything the state can do differently to?
Yeah, I mean, I think when you see these more expensive products come to market, there are patient registries, right, that help with enrolling patients in clinical trials. There's other opportunities to kind of expand that with patient advocacy groups and those types of things, right? What needs to happen is there needs to be a true partnership, right? And I think we talk about partnerships, we talk about all of these things, but having a true partnership with a PBM and a Harvard Pilgrim, for example, what we're seeing is that manufacturers that really have worked, look at the strides that have come along, right? You see academic medical centers now that have the KOLs, they have the private investigators that are helping run the clinical trials. They're all mostly at these large academic medical centers. There's been great strides from that perspective, from a manufacturer's point of view. Now we need to move that on with the payers, right? And have the payers involved in some of those things as well. And there's an abundance of data that can be brought together if we could get those three pieces combined together. From my earlier statement, the one entity that has both the pharmaceutical and medical side and your holistic view of your data is the payer, right? That's the only one. And you can really tap into some of the things that are going on in these academic medical centers from a clinical trial perspective. But to your point, all the things that have moved in the market, the trends that have shifted over the last couple of years, clinical trials, the length of clinical trials have really not changed that much. Products have been approved earlier, which has caused other problems on the back end, right? But the way clinical trials are typically run, you don't see much change there. Now you have companies like Emulate that are doing organs on a chip. Maybe there's some opportunity there, but that's transformational, right? That's a long time out. But I think if you can find pockets of patients, chronic patients, right, where you have a progressive pharmaceutical company, manufacturer, and a transformational product. You have to have both. The company has to be progressive and willingness to work with other stakeholders, and they have to have a product that's transformational, whether that's transformational mechanism of action or route of administration or whatever it is. And then you have to find a progressive IDN, fully integrated IDN, and then you have to find a progressive payer. And if you put those three together and you're willing to run a couple pilots in a certain disease population, I think you can really tap into some innovation.
Okay, so any other reaction to that? Trying to use what we have here in Massachusetts to reduce cost?
Well, I would say, especially with regard to sort of gene therapy, there's a number of ways that it works with regard to the sort of value-based parts that it's actually a great value-based concept because it's a relatively sort of small number of patients and there's very specific outcomes. These are almost all monogenetic disorders, so you know if things are not working out. So, and I think, our discussion with many of the biotech manufacturers, even here in Massachusetts, they're quite convinced that the therapy is going to work. So one thing you would do is basically get a warrant on it and get a full rebate if it turns out that the gene therapy doesn't work. Now, in order to do that, you have to be able to follow a patient. And you imagine this patient's employed by this individual company at this particular point, and they've got this insurance. The employer could change insurers, the employee could change employers, so it's that point in time where the responsibility is for the payment. So as an insurer, you're going to have to follow this person for 4 or 5 or 6 years afterwards, but may not have an insured relationship with them.
So David,
the state could facilitate that.
you're likely to hold on to these patients longer than Aetna is, right? So theoretically, there should be more of an opportunity for you to benefit, right?
Yeah, sorry.
I was just going to finish. It doesn't matter as long as the state allows us to sort of have a contract that follows that person along. And for instance, a kid with SMA, do a neurological examination, every 6 months to make sure that Zolgensma has worked. I'd say the other thing is that it's a very peculiar area because most of the genes are not patented, or if there were patents about them, they lapsed a long time ago. And the same thing's true with the envelope that you insert the gene with, the so-called adenovirus. They're almost all using adeno-associated viruses now, so-called AAV. And the patents on those are starting to run. And the clinical trials are very small. So you could actually begin to see some low-cost players come into this, even university consortiums who might be willing to manufacture the gene therapy. And then you could work that out so that it wouldn't have the inflated price associated with what you're seeing in biotech. It probably wouldn't work for the very prevalent things that people are looking at right now, like sickle cell anemia or thalassemia, but especially for the very ultra-rare diseases, that might be a good way to go.
Yeah. Okay.
Chris, can I just jump in on this,
Sure.
this very specific point? I thought one of the drugs in the vanguard of this was Kymriah for ALL, and they had a value-based payment with CMS that CMS just canceled. And that was based on 30 days. So I was like very upbeat on it, and I'm now turning more sour on these because like even the easy stuff seems to be too hard to do.
Why did they kill it?
I don't know, they didn't say. They wouldn't say.
I have a couple comments. One is to tag on to what Aaron said about lowering the cost of research, because I think you were asking that question first before value-based. And I agree, using kind of innovative and progressive IDNs, and we happen to be one with an attached health plan, could shorten the cycle of research a great deal. I think a second point, and if there's a way for a state to facilitate this, it is difficult, I think you would agree, just the recruitment time to get appropriate number of patients into a trial to power that trial in a way that gets outcomes that are meaningful is difficult, largely because the way that we recruit patients is in a large academic medical center that has to wait for somebody with a particular type of cancer and mutation to show up and then try to enroll them. If there's a way to kind of democratize that out into the community in a less expensive way and get to your 5,000 patients quickly, Massachusetts could lead and be an innovator to accelerate research. Plus, we have these ACO mechanisms, and we're a leader in that regard as well. Put those things together. I'll add a third point, which is, I think this is emerging as a trend anyways, but certainly our health system has leaned in quite a bit, using, instead of just, and it's not in place of, but in addition to pure research, but using quality improvement frameworks. And so not depending completely on, what I would call pure research, and I'm failing to find the right words on this, but instead like the IHI model for continuous improvement and PDSA cycles. We've done a lot of that in our health system because we didn't have the funding or the time to work through a pure trial, but we've been making strides. If you can integrate that into drug development, I think it could accelerate the timeline as well.
So we have time for one or two more questions. We'll give Michael Carson a chance to respond, though, with regard to value-based contracts, because Harvard Pilgrim's been
For sure.
at the forefront. What's been the hardest part about delivering on those value-based contracts?
And I think it ties in nicely to, I think, what Aaron laid out in terms of the opportunity that some integrated efforts have for us. We now have 12 active contracts, 15 in total, but David, as you pointed out, some of these sort of start and get stopped. I would say that we're scratching the surface. We're trying to lay the path for deeper value-based relationships, but they're all still in very early stages of development, and quite frankly, don't reach enough of the population. Sometimes we have to look at the motivation, and oftentimes the motivation to engage even in a value-based contract with the payer may be just to get the drug on the formulary, but doesn't necessarily have the broad impact yet. So we need to continue to find ways to have more people involved in the value-based contract, more patients involved in the value-based contract, but also the right kind of drugs. We're not able to get this kind of value-based agreement on Humira, for example. The number one cost in drug, ICER stipulating that it's not a substantiated price. Those kinds of drugs aren't making themselves available to a value-based relationship. So the ones that we do have, so a couple to quote currently, one with Novartis on Entresto, so it triggers a reduction in cost if patients experience higher hospitalization rates than they did as projected. And then one with Amgen for Repatha, a drug used to obviously treat cardiovascular disease, where there's a complete reimbursement to the member and to Harvard Pilgrim if there's a cardiovascular event during therapy. So these are all the right steps to take. They're just not widespread enough yet. And I think we need to continue that path forward. And again, as Aaron pointed out, in collaboration with provider systems, in collaboration with the broader aspect of the healthcare system. We're currently having conversations with Dana-Farber on various clinical pathway initiatives for cancer care. So obviously having value-based agreements as well as an integrated partner and then a value-based agreement on an oncology drug, perhaps gets us to a place where we're really making a dent in drug prices going forward.
Thank you, Michael. Sorry, David, I'm going to
I would just say,
pass
so
to,
can I just,
go ahead.
so those are examples of value-based contracting. What you said earlier is not an example of value-based contracting. It's just a financing mechanism it's like a mortgage payment over time. So I'd like to just be clear about what a value-based contract is.
Thank you for that clarification. Tim Foley?
Yeah, thank you. Just had one quick comment and then a quick question, I think, as well. I think I heard Aaron say the word partnership, which I think is a really important word here in Massachusetts, as we've been working together, the consumer community, the employer community, the payer community, the provider community, all coming together to figure out what we can each do to reduce overall cost of healthcare so that consumers can afford the care that they're being asked to pay for. And I think what we found at the last cost trends hearing in this is that, speaking for myself, I think we're looking for some partnerships to figure out how we can work together to address this issue, and there may be some pain involved in that process, and I just hope that there's an opportunity to continue that conversation, because that's what healthcare reform is meant in Massachusetts, and that's how we're going to try to address overall costs. I think that's a really important word that we should keep in the back of our minds as we're figuring out how to address these real costs. And then I just go back to the first slide that David presented, where it says estimated a 6% increase in pharmaceutical spending that's expected. And I guess my question is do you think that we should accept that? And if not, what's the right percent increase that we should be expecting that you think is fair and reasonable, particularly given the earlier conversation that the people that are being impacted the most are consumers of healthcare right now, and those costs are going up. And so is 6% something that we should accept? And if not, what should be the right number of percent increase?
Last year, our clients had a 2.1% increase. So, and that was based on a 1.6% increase in utilization and a 0.5% increase in costs. And I think we had about 45% of our clients who actually had a deflation, and about half of them have had deflation over the course of the last 3 years. So I think, there's a lot of statistics out there. We're testifying under oath. Our numbers are the numbers from our book of business, and I think that's reasonable. I'd say the healthcare system today cannot stand any inflation as the population ages, and so everyone should be aiming at something that looks more like flat rather than 6%.
We have, we'd like to see a low percentage as well. I think we've thought about it. We have thought about it slightly more holistically again, and I think, Aaron, you touched on this very early. We are trying to understand the interplay between the pharmaceutical expense and the total cost of care. And really, it is $1 and $4 for us as well. But if I make it $1 and $3 and the total cost is actually less, I would be okay with that. I'm really interested in two things. One is the lowest possible cost to do it and the highest quality care that we can provide to the patients. There are times we increase the amount that we spend. We have gotten more Vivitrol into the patients of more patients with SUD, and that has increased our drug expenditure, and that's okay. And actually our utilization numbers are quite different than that, actually, because we've specifically gone out and tactically in our ACO tried to get more members who needed medications. But to sustain at 6% across the board, we agree would be untenable. There's just a careful balance we're trying to strike between the right thing to do for patients, the right care to provide them, and then the overall total cost of care is what we're trying to deliver.
Unless there's urgent, go ahead, Aaron.
I was just going to say it's one of the levers to pull, right? There's multiple, as David pointed out, there's 4 or 5 different levers that you can pull in the healthcare system. Pharmaceuticals is one of those levers. And if you ask physicians what's the best way to manage their patients, many times, almost a lot of the time in the research that we've done, they will say pharmaceuticals is the best way to manage their patients, in addition to coordinated care, right? And so the more coordinated care that we have, if you go see an endocrinologist, are they talking to a neurologist? Probably not, right? I mean, if I go back and try to find my own medical history, it's very difficult for me to put together, right? And I work in the space. So I think the coordination of care, appropriate use of pharmaceuticals, making sure you're identifying the patients that actually are going to get the value of the product, right? It really goes back to, do you really feel like you're paying for value? Not only in the pharmaceutical, but in the healthcare that you're actually receiving. And I would say that's a struggle in the industry right now in general.
Certainly agree with
Last
the value.
word from Michael Carson.
Certainly agree with the value statement. I think overall, we need to be focused on total medical expense, and any action, any service, any drug that gets contributed to that cost needs to all be driven toward better health outcomes for our members, as well as a better management of total medical expense. At the end of the day, there are so many, you spoke of levers, Aaron, there's so many levers that we try to work on behalf of our members and accounts. The lever of list price on drugs is not one that's manageable for us. And that's where it becomes tricky for the health plan industry, that it's not a lever that's, none of it's easy, but it's extremely difficult to address the list price issue.
I think with that, we'll wrap up, but we'll ask you four to go into a room and not leave the room for the next 24 hours in the spirit of cooperation to figure out how to solve this awful problem.
Thank you very much.
Thank you very much.
Okay, we are moving to that part of the program that is public testimony. I'll be calling folks up. I have to say, we're going to limit testimony to 3 minutes per speaker. Our first speaker is Bonnie Gilbert from the Greater Boston Interfaith Organization. Bonnie.
Good afternoon. Thank you for having me. My name is Bonnie Gilbert. I'm a member of the Greater Boston Interfaith Organization Strategy Team, otherwise known as GBIO. co-chair of the GBIO Healthcare Team and a member of the Health Policy Commission Advisory Board. GBIO is a community organizing organization comprised of 41 dues-paying religious congregations and other institutions representing about 40,000 individuals who come together to advance social justice, including issues related to healthcare costs, access, and quality of care. During this legislative session, GBIO is also, along with everyone else here, focused on lowering the cost of healthcare. In particular, we are working for lowering the cost of prescription drugs, increasing access to afford mental health care and substance use disorder care, and regulating out-of-network surprise billing. Our members continue to struggle with these issues, and while we don't expect these all to be resolved in this legislative session, we are hoping that significant progress can be made and can dramatically reduce suffering here in Massachusetts. So today, everyone present here today and tomorrow is focused on the costs of providing care. And GBIO would like to thank the Health Policy Commission for its continued excellent work to raise quality and lower the cost of care in Massachusetts. But now we would like to talk about prices paid. While one might think that lowered costs would automatically mean lower prices, as we can see here in Massachusetts, that just isn't so. Prices of pharmaceutical, prices of services and providers, from out-of-network services to price variation, all continue to rise. And while the 3.1% benchmark was not exceeded this past year, out-of-pocket costs for the consumer went up by 6.1%. Augmented coding is only the newest mendacious methodology used to increase the prices paid by consumers for health care. Hospitalization is down, so should be our spending. But as we see, they continue to escalate. GBIO fought for the creation of the benchmark, and we laud the excellent work done by the Health Policy Commission in monitoring, reporting, investigating, and creating policy recommendations impacting both the benchmark and the factors measured by the benchmark. However, we believe that more is still needed to be done. How else do we explain that providers are able to lower their own costs with lower utilization, increase their revenues by augmenting codes, and manage to come in just at the benchmark rate of 3.1%, while consumers bear rising costs at a rate of 6.1%, more than double the 2.9% inflation rate? If utilization is falling, then some of those savings should be felt by consumers. GBIO and our members are grateful to the HPC for all of their work, especially in bringing these problems to light. But much more work is needed. We need our government agencies, our political leaders, our legislators to move beyond cost containment and focus on the prices being charged and the out-of-pocket spending by our residents. Until prices are addressed, the residents of Massachusetts will continue to bear the brunt and continue to struggle to avail themselves of the high-quality health care in which the state takes so much pride. We thank you for the opportunity today.
Thank you, Bonnie. Our next speaker is Christopher Carlozzi, State Director of the National Federation of Independent Businesses. Christopher.
Thank you, Mr. Vice Chairman and members of the Commission. My name is Christopher Carlozzi. I'm the State Director for the National Federation of Independent Business. We represent over 5,500 small businesses across the Commonwealth. Our members are in all types of industry, from manufacturing, retail, wholesale, service, and agriculture. The average NFIB member has roughly 5 employees. In short, we represent small Main Street businesses. Small business owners in Massachusetts have ranked the cost of health insurance at or near the top of their list of concerns for over a decade. The price tag of health care in the Commonwealth is a significant cost of doing business and a significant consideration when creating a new job. Unfortunately, health insurance expenses continue to increase annually, and efforts to get cost increases under control always seem to fall short of expectations. Health insurance costs are not contained within a vacuum for Massachusetts small businesses, facing operating and labor cost increases across the board. Our state is prohibitively costly to run a small business, with highest in the nation energy costs, mandated leave benefits, $15 minimum wage, the soon-to-be expiring EMAC assessment, and a new,
It is expiring.
you will hear extra chairs on New Year's Eve, Secretary, and the new paid family medical leave tax. Each of these labor mandates make it harder to offer health insurance and coverage for workers. But offering solutions to make health insurance more affordable for small businesses and their workers who shoulder the premium costs are often politically difficult to implement. Meaningful reforms are often stripped from legislation, and bills that do end up progressing result in higher costs. The answer must include more transparency for consumers, more choices, and more competition. NFIB is strongly in favor of more free market solutions to lower costs through competition and choice. One way to lower costs for small businesses is fewer health mandates. As many as 54 specific services, treatments, supplies, practitioners are mandated by law, including 22 new mandated benefits since 2006, many above and beyond federal essential benefits. Most important to remember is that these mandates fall disproportionately on small businesses. Businesses that are large enough to self-insure or multi-state or multinational companies do not abide by state mandates as they are regulated by federal ERISA law. Some of these comments may seem very similar to comments I made at the benchmark hearing. My repetition is deliberate because not much has changed for Massachusetts small business owners. They still see their premiums increase annually. Not as dramatically as 6 or 7 years ago, but they are rarely seeing savings. While small businesses may have met, while Massachusetts may have met the growth target, premiums are still on the rise, and workers and business owners are paying higher out-of-pocket costs. In short, small businesses and their workers are still grappling with increased health spending. Massachusetts has addressed coverage and quality. Now it is time to address the third leg of the stool, cost. I was encouraged to see Governor Baker call for Merged Market Advisory Council. As you know, the merged market was expected to increase small group premiums but lower expenses for individuals. Now we will discover to what extent small group is cross-subsidizing costs for individuals. For the sake of the economic well-being of Main Street businesses across Massachusetts and their workers, we must work to reduce health insurance costs for thousands of struggling small businesses. Thank you.
Christopher, thank you.
Quick question, Mark. Do association plans hold any opportunity for you?
I think to some of our members, yes. It depends on what type of businesses you're asking and talking to. I mean, it's industry by industry. But it is something that is on our radar screen. Thank you.
Thanks. Susan Fendel, Senior Attorney, Mental Health Legal Advisors.
Thank you for this opportunity, and I hope that the Health Policy Commission will consider us a sister agency, even though we're in the judiciary. The MHLIC will be submitting written testimony with explanations and cites to research supporting what I'm about to say. We are gearing our testimony to the recommendations of the Health Policy Commission in its last report. The first thing I want to mention is that we hope you will not pursue integrated care for the sake of integration. People with psychiatric diagnoses have legitimate reasons to fear integration of care. People with psych diagnoses experience a greater disparity in healthcare and in longevity than disparities due to race, socioeconomic status, geography, and it is not due to the lifestyle choices or access to healthcare of people with psychiatric diagnoses. Rather, it is due to diagnostic overshadowing, where an implicit bias against persons with psychiatric diagnoses and physical health issues are attributed to being, it's all in your head. In fact, that is the #1 complaint our agency gets concerning the healthcare system. If pre-filed testimony from people with psychiatric diagnoses was sought, they would say, please give us more access to control over our mental health information and which providers can see it. They would also ask that if integration of care is being pursued, that there be careful monitoring of the physical health care of people with psychiatric diagnoses to ensure that their physical health care is not diminished. We support the use of peer support specialists, and we hope that the commission will set standards for the hiring of peer support specialists, and in conjunction with existing peer groups, clarify the role of peer specialists as colleagues rather than underlings to other medical staff. We are opposed to most of the demand-side incentives. Demand-side incentives don't reflect the actual behavior of patients. Some are too sick to shop. You've heard that people rely on recommendations of doctors, and even more so, friends and family. People want continuity of care, which limited networks often disrupts. And higher copays due to tiering and deductibles leads to avoidance of care, delayed and foregone care, medication non-adherence, more emergency room use, and more hospitalization. Lower costs can actually be achieved by giving people more choice. People with psychiatric challenges would much prefer the lower cost of peer respites than inpatient hospitalization. They might choose emotional support animals, art classes, exercise, transportation to social events, and queuing, as opposed to reliance on other more expensive medical interventions. And all of those, by the way, have support in research as being helpful to people with psychiatric
Susan, 1
diagnoses.
minute.
1 minute, okay. I again caution about designating certain services as low value. Last year, MHLAC testified about the problems with the evidence behind that designation with respect to social determinants of care. We support addressing those issues, but we hope that it will be more than just ACOs referring people to agencies that already don't have any money. And we think that erroneous appeals by insurers and ACOs should have a financial incentive attached to them, because right now there is a financial incentive to flippantly denying care because they know such a small percentage of people will appeal a denial.
Susan.
And more is in the testimony.
All right. Thank you. We'll look forward to your written testimony.
Thank you.
Thank you. We have Dr. Lachlan Foro, Chair of the Mass DPH Council on Palliative Care.
Hi, thank you for having me. I'm going to just mention briefly 2 topics, and I'm mostly looking at David, who I hope you'll encourage me to follow up with. I've testified at length in past years about the topic of care through the end of life. I'm not going to repeat that because I actually have the same message before, which I'll resend to David. I have details of the testimony. But just to remind you, from the report that you all did, David and his staff did in November 2016, a 2016 Massachusetts survey found over a third of people with a loved one who died in the last year said the healthcare providers did not fully follow their wishes. Did not. Well, that's overall. For non-white, lower socioeconomic, it was far worse. 20% rated their loved one's care as fair or poor. Only 27% felt it was excellent. For non-white, lower socioeconomic, it was far worse. David and his staff did a wonderful initial review of Medicare expenditure variation and hospice use variation across the state, and suggested in that we really need to have statewide outcome measures that I recommended in detail last time, and additional data collection. I'm going to stop here, but I just want to make sure this stays on your radar screen. I'm not aware of additional work since 2016, but I'd love to help. The second topic I really want to have on your radar screen, which I know is implicit in a lot of what we heard about, but I think needs to be more, I hope will be more explicit over the next year, is health equity or health inequities. The $60 billion or whatever totally we spend in the Commonwealth, we all know that on almost every measure, lower socioeconomic and especially non-white members of the Commonwealth are doing significantly worse and are some of our highest cost people. Monica Burrell and others at the Department of Public Health have worked for 2 years in really developing a framework how to even think about these issues, but we'll have a lot of work to do. I hope we can link this next year to celebrations in the summer of the new MLK Coretta Scott King sculpture that's going to be the bronze sculpture, The Embrace. Dr. Martin Luther King said in Chicago in 1966, as you know, of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. What I would like to do to offer, if I can work with Dave and other staff, about how do we crystallize for the people of the Commonwealth, particularly young people, particularly health professional students, what these shocking inequities are and what people can do about those, then I've led in Boston organization of what we've called Boston Schweitzer Fellows, doing service in local communities. We've had over 400 Schweitzer Fellows. Looking at Don, 2 of them who, when they were at Harvard Medical School, spent a year working with the underserved were Rushika Fernandopoulos and Sachin Jain, who then have gone on to devote their lives to work in this, and hundreds of others. We paused that and will be relaunching the Boston Schweitzer Fellows program next year, but really designed to have more systemic impact, including the students, their faculty advisors, and other schools, to make sure everyone in the Commonwealth, particularly young health professionals and others, understand the exact details of health injustices that are so shocking, responsibilities of individuals and organizations, and I think the data and framing that you guys can provide will be enormously helpful. So David, I'm going to be in touch about that too. And Secretary Sutters, my hope is that we can launch next year with Governor Baker, who I know cares deeply about these issues, and Monica from her years at Healthcare for the Homeless, perhaps as part of the MLK breakfast that launches perhaps a 2020 year, including up through the hosting of the NAACP National Convention. So if anybody would like to talk about ideas of all the multiple hooks for that, I think we have work to do that we would all be proud to make more progress on than we currently are. Thank you.
Thank you, and thank you for reminding us that health equity is at the base of everything we should be doing. Any other speakers wishing to testify? Any other? Hearing none, we'll close the public testimony. It's been quite a day. I think we want to thank all of our presenters, all of our panelists. I want to also commend the staff of the Health Policy Commission for putting this all together. They've done a wonderful job as always, so we appreciate it. We will reconvene tomorrow at 9 a.m. We have another full day of both presentations and panelists. So get a good night's rest. Thank you.
Nice job, Marty. Good day. Good job.
Are we leaving these booklets here, or should we take these?
No, I didn't.
I think up in the room, right?
Definitely a compelling.
Commissioners, you can leave your binders here. If you want.
We can leave them here.
We can leave.
Okay,
Leave
good.
behind us here.
All right.
Lugging it back and forth.
Things here.
Thanks. Thanks, Don.
Laura. We'll see you tomorrow.
See ya. Sounds good. Look forward to it.
See you tomorrow. Yeah, oh.
That was good.
Thank you. I mean, I was going to ask you to this because, yeah, your incentives are great for new
I'm so surprised that there isn't like record 25 or record.
rationalized the races.
I know, mine.
Thanks.
Hey.
My
stuff.
Yeah.
We're on vaping
Yeah.
lawsuits.
Thank you.